Now let us see the kidney stones. About 10% of kidney stones has uric acid stones, uric acid. And gout is largely a disease of men. It is largely diseases of men. The male-female ratio is 9:1. The first attack of podagra typically occurs in patients in their 30s or 40s, although acute gout may present at any age. In fact, in up to 20% of men who have one attack of gout, a second episode never follows. You see, there is no guarantee for recurrent gout attacks. Many people, they do not get a second attack of gout. That goes as much as 20% of patients with gout. Now, the laboratory findings, the fundamental abnormality in gout is excess uric acid. And in fact, fewer than 25% with elevated uric acid will have. See, the fundamental abnormality in gout is excess uric acid, but excess uric acid does not always lead to gout. In fact, only 25% of people with excess uric acid levels will have, let me see a page. Okay, you see, in fact, less than 20% of patients with excess uric acid develop gout, and other things that raise during acute attacks of gout are WBC. It slightly elevates and it reflects acute inflammation. In long-standing gout has caused renal insufficiency. Elevations of blood urea, nitrogen, and creatinine are seen along with other electrolyte abnormalities. And when the patient has exposure to lead, that actually increases the renal side effects of the gout. We call it as saturnine gout when lead is involved as one of the incrementing agents in this disease process. Now, gout is generally due to either inappropriately low renal excretion of uric acid or abnormally high endogenous production of uric acid. You see, we need to remember this. Either decreased renal excretion of uric acid or increased production of uric acid leads to gout. That's why the basic drugs we use in the gout, the probenecid and allopurinol, they act on these two basic mechanisms. For example, allopurinol, it decreases the synthesis of uric acid in the body. That's why allopurinol is used in the prevention of gout attacks. In the same way, probenecid actually inhibits the reuptake of uric acid and it increases the excretion of uric acid. That's why it has that role in the prevention of gout attacks. Now, collecting a 24-hour urine for uric acid and creatinine clearance can be instructive, and you should do crystal examination of synovial fluid, and that's very important. Now, not all monoarthropathies are due to gout. There is a long list of differential diagnoses, but personally the most important are inflammatory and non-inflammatory. There are inflammatory conditions, crystal-induced, like gout, pseudogout, and appetite. And there are infectious monoarthropathies due to bacteria, fungi, Lyme disease, TB, and viruses. There are systemic diseases that cause monoarthropathies like psoriasis and other spondyloarthropathies, reactive inflammatory bowel disease, writer's disease, and systemic lupus erythematosus. And also, there are non-inflammatory causes for monoarthropathies like fracture or meniscal tear or osteoarthritis, tumors like osteochondroma, osteoid osteoma, PVS, pigmented villonodular synovitis, cancerous osteonecrosis, and cancer and hemarthrosis. All these causes lead to can be the causative factors for the gout. So it's not just all of them can be causes of monoarthropathies, not just gout. Now, synovial fluid analysis helps a lot in the differential diagnosis. When you take gout, from the examination point of view, the following things are very important. In gout, the crystals are needle shaped. Go needle, that is the a memory aid. Go needle. Needle shaped crystals in gout and negative birefringent. And then pseudo gout. The pseudo gout, you have rhomboid shaped crystals and positive birefringent. You see P and P, pseudo gout, positive birefringent, and R is close to P. That's why pseudo gout, rhomboid shaped crystals. That's very important to remember because many questions come from those 2 points alone. Now when you take an X-ray of the patient with gout, most commonly you see phalanges with lateral erosions, distal bone cysts, or the presence of fluffy tophaceous material makes for exciting findings of gout on an X-ray. But the problem is not many people go to that stage. So most often you find very non-specific features on the X-rays from this patient. Now let us come to the most important points in the treatment section. You see, treating gout is not a big deal. All you need to use an anti-inflammatory agents like NSAIDs, and they take care. I mean, in the previous days, indomethacin was recommended highly for this disease, but nowadays you can actually treat this with a simple NSAIDs like ibuprofen or naproxen. That's all it is needed. So the problem with the treatment of gout is not the treatment of acute gout, but the treatment of the recurrent attacks of gout. How we are going to deal with the recurrent attacks, that's going to be the main exercise for the treatment of gout. And the colchicine, for example, very important in the acute treatment of gout. You can give it as 0.5 or 0.6 mg tablets every 1 to 2 hours. And the most important side effects of colchicine is diarrhea. Even before the 6th pill is taken, generally the patient develops diarrhea. And you can also use corticosteroids, prednisone and methylprednisolone, triamcinolone can be used. And coming to the prophylactic medications, as I said earlier, probenecid and allopurinol. As I said, the 2 main mechanisms causing gout: number 1, the decreased excretion of uric acid from the body; number 2, the increased production of uric acid in the body. So both of these causes gout. So probenecid deals with the first mechanism, increasing the excretion of uric acid. So the under-excretors should take probenecid for the prevention of gout attacks. On the other hand, allopurinol, it actually decreases the synthesis of uric acid in the body. So whether the patient is under-excretor or over-excretor, he should take allopurinol. That's a very important point here. But probenecid is contraindicated when the patient has uric acid stones. Why? Because probenecid, what does it do? It increases the excretion of uric acid, and that excreted uric acid might directly go into the uric acid stones, and that's why it is contraindicated in that. So finally, we have seen that NSAIDs and colchicine in acute treatment, probenecid and allopurinol in the chronic treatment, and the needle-shaped crystals in the gout and rhomboid-shaped crystals in pseudo-gout, the negative birefringent in gout and positive birefringent in pseudo-gout. Hope you remember and do well on your examination.